Well, good afternoon and welcome to today's O'Brien Institute seminar. I would like to take this opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta. This includes the Blackfoot Confederacy comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda. This includes the Chiniki, Bearspaw, and Wellesley First Nations. The City of Calgary is also home to Métis Nation of Alberta Region 3. My name is Jessica Naidu, and I'm a PhD candidate with the Department of Community Health Sciences. I will be your moderator today. During today's presentation, you may ask questions using the Q&A box, and we will answer them afterward during the Q&A session. The webinar will be recorded, but if you have follow-up questions, you may contact iph@ucalgary.ca. Our speaker today is Dr. Turin Tanvir Chowdhury. His formal biography provides us a snapshot of his accomplishments. He is an assistant professor in the Department of Family Medicine and the Department of Community Health Sciences. He also has published nearly 400 academic contributions. He leads a program of research using community-based participatory research and integrated knowledge translation. And he's been involved in research training and mentoring both nationally and internationally. I've had the pleasure of being one of Dr. Chowdhury's students, and I have known him to be a fiercely supportive supervisor. He is attentive to his students, getting to know their strengths and passions, drawing upon them and constantly pushing them toward their academic goals. He does this with such a calm and cool demeanor. It's like a mentorship sneak attack. For example, all of my PhD mentorship has come in the form of baking analogies. So not only have I accomplished my academic milestones, my bundt cakes are really on point. While Dr. Chowdhury is clearly in a position to teach and mentor others, in the time I've known him, he has demonstrated humility and willingness to learn from his students and the community. So he's truly dedicated to being guided by the community, as the title of his presentation says. In this time, I've also seen his dedication and strategic action toward amplifying the voices of immigrants, refugees, and racialized communities. Finally, he's just a real fun guy. I'm honored to work under his supervision and to introduce you to him today. Without further ado, Dr. Turin Tanvir Chowdhury.
Hey, thank you, Jessica. That was awesome. I didn't know I was so good. So thanks for that. So just a quick question. Can you guys see the slide properly? I hope so. Okay, so I will be sharing today with you guys the story of my journey. And it's been a not that long journey. Yes, as a researcher, I have a long journey, but the journey of this work that we are trying to develop and how it unfolded and how it taught us also lots of things. So to give you a background, I am basically has been trained as a number cruncher, like epidemiology, biostatistics, big data analysis, and modeling and prediction modeling, those, fancy things that we can do, this awesome things that we can do. But when doing research on different type of epidemiological issues, like what is the trend of the cardiovascular disease in Japan? What is the injury rates in Bangladesh? Or what are the, chronic liver disease condition in Nepal? Or coming to Canada, what are the what does fluctuation in kidney disease mean, and how does it affect people? So those all things, when we did, it was great. We published a lot, but lots of time I was a little bit, it bugged in my head, like, okay, so Turin, you did this nice thing, you presented it, nice graphics, so what? Because when a person comes through the doctor's door or comes to the health service, they don't come only with kidney disease. They come with lots of other issues. When a kidney disease person come, they always normally have, hypertension or other comorbidities with them. And what about those social determinants, like, that brought them to this level in this moment? Like, are they from a family where they can maintain good food habit? Are they in a place where they can be physically active? Those things. So all those things, like used to be in the head. So I think one extremely helpful experience for me was, so this is a paper we published. It is about lifetime risk of diabetes among our First Nation population and non-First Nation population as well. And we showed like uh, the disease burden in Canada among the First Nations as well as the non-First Nations are quite high, but it's more higher in our indigenous communities. So when we write a paper, especially epidemiological paper, we have to write a discussion section where we need to defend our finding. So one way of defending, I was saying that, the bad food habit and this and that, sedimentary lifestyle. So we submitted it to CMAJ, Canadian Medical Association Journal. It's the top ranked journal of Canada. So I think my learning came from a comment from the associate editor. The editor sent the back paper to us. And then they said like, oh, we love this. We like this paper. We would love to take it, publish it, but you need to change few things. And that's a normal, process in academia. But the comment of the editor was, Dr. Chowdhury, the way you, supported or tried to defend your finding, it looks like you are blaming the First Nation population for this problem. And, this hit in my head. And then I started digging into it. Like, why would they say that? Because I said sedentary lifestyle, difficult food habit. So it's more of at that time, the realization started kicking in, like, oh, the social determinants of health it's much more beyond than simple the way I put it down there. So after 6 or 7 months of extended work, I managed to, put something there which made sense to them. And that also put me in a very strong spot. Okay, so what type of research I want to do? Because in this phase of my career, I had a very important, there was a very big move. I moved from community health sciences to my current department, family medicine. And my departmental head and me, when we were discussing what type of research to build, this was a crossroad. Should I take the road on the right, road on the left? Should I go straight or the other road? Because here I managed to think about, okay, so it's a so what thing, and can I do something to fulfill my inner burning questions that has been coming towards me during my whole, the training period and the postdoctoral period and the initial academic period. So I wanted to take advantage of where I was, like in the Department of Family Medicine, Community Health Sciences, O'Brien Institute, Libin Cardiovascular Institute. And then based on that, playing on my strength at that moment, I said, okay, so I will be trying to do research. I hope to try to do research on primary prevention, equitable access of the community people. So this was one of the, like you always become in a crossroad and you make a decision and that defines your journey. So this was a self-reflectory decision, talking with my mentors, talking with my peers. I decided I want to build on this side. Then what happened? Then again came another crossroad. Okay, so you decided to build on this angle. Now you decided one road and you went ahead a little bit. There is another crossroad. That crossroad was lots of people do research in different ways. You will see that people say, I'm a diabetic researcher. People say, I work with the homeless and the socially vulnerable people. Or lots of people say, I am a service delivery researcher. Lots of people say, I'm a methodologist. So I had to define myself. I have to say myself, okay, so you decided you will be in the community, you will be in the primary prevention, equitable access, and those components. Where will you create your home then? So with the discussion, and again, playing on my strengths, on my own identity, I decided I will go with the population and interest, and my research and program will be around the racialized and immigrant population because of my own understanding of the issues we have, own understanding of how improvement can improve our lives, how research can contribute to that. So based on that, I sometimes call it glocal health. So it's not a spelling mistake. It's more of a glow for global and cal for local. So it's a global health, because like we all bring our own identity, own culture, own way of doing things in Canada, where we are trying to create a mosaic. So, as any, like a newbie, because I will call myself a very newbie in this domain, I started taking an inventory, doing an homework. How did we do the homework? We read. We went to library. It's more of a read, learn. So we started reading about it, and then like we published first. We understood first about the barriers to access to primary health care, and then we went on and our summarizing started coming up. It's for our own understanding as well as sharing with the people around us. So from that step, after doing the few initial steps like that, making ourselves savvy that we can go out and talk to people, we started talking to people. We started talking to community cultural associations. We started talking to not-for-profit or service providing organizations, other academic and social work, and others within our community school, and Alberta Health Services, City of Calgary. So it's more of a trying to identify, if we want to build something here, what will be the ecosystem? And within that ecosystem, who will be the people we should definitely talk to? And we started talking to them. And then, a beautiful thing happened. Lots of people within this ecosystem uh, was generous enough to guide me or to be our sounding board. It was so great because we got diverse viewpoint. We got partners. We are not thinking in silos, and we got relationship where they gave us honest opinion, and then helped us to plan. And all those components combined was shaping up what we are trying to do. So you see, this type of shaping up through consultation in the initial stage, I think I will feel like I was super duper blessed to have this experience, and this diverse people contributing to this as a sounding board to our step forward. So a couple of things we realized. So do we need to do any more problem identification research? Or it's probably a high time we do solution oriented or implementation research. So I put a question mark there because in our initial days, we are pretty sure we don't need to do any problem identification. We have a decent idea from previous researchers, experience, like going through those reviews, learning from what other people have done. We have a decent idea what is the problem. Probably we need to focus more on the solutions. I put a question mark because that changed a little bit during the end of our process, like in 2020-21. But again, as a whole, we have a lot already done on problem identification. So again, so this put us to another crossroad after doing this homework and everything. So the crossroad was, okay, so any problem, if it is a problem, like it can be improved by different angles input. For example, if you talk about access, one angle to work on it is like, oh, can the system be change themselves to be more accessible? There can be other things like, oh, policy, can the policies or activities can be so much that they make the system's service improvement, or even the people to be accessed more. So this is angle from another angle. Another angle is like, can we, us, ourselves, the own community population, the citizens, can we do something a little bit differently where we can access also better? It's more of a, meeting the system or the service in a halfway. So it was a discussion point on us, like which road we will take. We know that our Community School of Medicine is one of the most strongest health service research focus in Canada. We have a strong policy school. Our OIPH that do a lot of policy related work. So then I thought, why not we place ourselves in the community level, in the grassroots community. I have an analogy to say, like, Canada, from we immigrants where we come from, most of the cases, Canada is a very decent place in terms of health care access or healthcare services. Still, there is a long improvement. There is room for huge improvements. But despite that, relative from where we come. So here, Canada, I feel, is like more of a good in spoon feeding people. So I thought if we can work towards, working with the people and mobilize them and empower them in such a way they can start hold the spoon and feeding themselves. I think there will be a strong improvement on the issues that we are working. So that motivated us to go for the community health and wellness side, working with the grassroots community, mobilizing the community around that. Again, few things we decided based on our discussion around us was, we are talking about primary prevention. We are talking about keeping the healthy people healthy. We are talking about keeping the communities healthy, where the people who needs treatment, they will go back to the same place, but they will go back to a better place, not to the place where they have become diseased in the first place. So that's what we are thriving for. That's what we thought we should be focusing upon. We promised ourselves we will do continuous engagement, because parachuting on approach is not should not be done. And this came from our realization for this, different organizations ecosystem member consultation, because there we heard a lot of time, oh, researchers do parachuting, get the data, go back. We never, lots of time we don't hear from them. So we promised ourselves and our partners, and we promised to the community that continuous engagement will be the way we will take things forward. Yes, we have a conversation. If we don't have money, if we have fund, we will run. We will do lots of events. But if we don't have money, we will do the minimum bare possible for us. But we promised we will be with you guys. You will be seeing us around. Then again, one more thing that came up was, don't miss the mass. What happens? Let me give you an example. Many of you might know this. What is this? This is a normal bell curve. We call it a normal curve. How we explain this? The most of the variables in the world can be explained by this one. Like, majority of the positive extreme or the negative extreme are smaller in volume. Most of the people belong here. In a rational world, we should have this type of scenarios. But on the other hand, like for example, in a rational world, we should see very, very obese people, very few in number, very, very lean and thin people, few in number. Majority should be here who are neither obese, neither lean and thin. But on the other hand, we know that this curve is shifting towards obesity in the North America, especially in the USA. So keeping that in mind, within the communities also, there are people, like whenever we want to do something, they will say, oh, Turin, I will help. There are people who are totally unengaged. Even if I, push them and put a gun in the head, they will say, no, let me sleep. But on the other hand, if we don't mobilize our activities of community to be involved and community to start, taking things on their own, we will not be able to make that change. So our idea is, can we move the general community members towards this positive health and wellness issues? Again, we have to go through the champions, because that's the modality, that's the way it works. You cannot, it's difficult to engage with the general community members directly. So we took the approach, the discussions we had through these champions, reaching out to general community members. And also we also started taking our information in a very general community members way. You can say that advertisement of what we do, and then making sure that we are present there in the community. So based on that, we call it meaningful community engagement. Means where there is a continuous community engagement, where we always thrive for not missing the mass. We are not, containing ourselves a checkbox style engagement by only talking to the champions, going in. And it's a journey, not a project. So what do I mean by that? It's the way we are looking at it. It's an infinite game. It's not a single project. For example, it's about being healthy. So it is summer, with the South Asians, we play cricket or soccer. If it is winter, we will play indoors winter. So the cricket in summer is a project. Indoor soccer in the winter is a project. But the whole game is about, hey, can we keep healthy? Let's do that. So, and one more thing we learned, like every baby step defines our next step, and taking baby steps, because it's overwhelming. We have given ourselves 20 years, 30 years to change, make things impactful, but we are doing it in a very baby step way, one step at a time. So this is a few journey points that I took some, right, left turns. So I took the turn towards equitable access and primary care prevention. And that was, with discussions in the community around me, my peers, my mentors, our students, all of them. Then we took the next step about this another turn after in another intersection or junction. Okay, I will be working on racialized immigrant population. That was support. That discussion I had was within my friends, within our grassroots communities. What do you think? And their guidance shaped me up. And then the third one came with the community level health and wellness. This is from again, now here, the contribution came from those guardian angels that that I find, the guiding angels that I found during our interaction with all the ecosystem members, that pockets that we identified we should be reaching out to. So where to start? Because that was $1 million question. We have been doing some small things here and there. We have talked to people. Now where to start? Because to us, it was not only about data collection. It was not only about improving the service, taking and making a decision. Oh, let's do it in this way. It's not only about the system change. It was about mobilizing the community as well. So that was a very, interesting phase where our discussion shaped our thinking. So the main thinking was, we lots of time take the approach of assumption-based approach, that we know lots of things, and in fact we really know lots of things because we are studying this. We have studied our previous predecessors' research. We have studied different news that's been coming up. We have been brainstorming about that. But when you are going to the community, you have to go with a blank slate because they don't know, or they don't have any clue, or they don't care how much you know, or they don't need to care. So it's more of a listening to the community, starting with a clean slate. And also one realization that came up was service to the community. So yes, why will the community engage with us? The general grassroots communities. They will engage with us if they see that their leadership, in a sense, I will call them influencers or the community champions, that they are okay with us. Like they have faith in our work. So that trickles down. On the other hand, we need to add to that. We need to come up with ways to engage, to show them that we really want to work with them. It's more of a, that gives the idea of like the things I did when I wanted to get a date out of my current wife at that time, to be girlfriend. I needed to show her that I care. I needed to show her that, come on, give me a chance. So that approach worked here. So now we wanted to engage with the community, but to do what? So we wanted to do the priority identified by the community themselves. And here came another realization. The community members, when we went to do those informal coffee chats and everything, when we went and then said, okay, Turin, how can we help you? Then when I say that I want to work on priorities that you identify for the community, you should have seen their eyes. They were just blank. Okay. So they were thinking to themselves like, what did I get myself to? What crazy talk it is? Then we realized that in general, the communities did not have the exposure or chance to think collectively for the community development or community work. That was a great realization because that was a way of we engage together as well. Because they have, it's more of a, my friends on an individual level. When they make decisions, for example, when they make a decision to buy a house, they take this idea like, okay, so I will buy a house that is related to this school because my kids, when they grow up, they will be going to this school, and this school is renowned. That's the way they shape their thinking. Lots of things come in their way, but thinking for the community, they never had that experience or opportunity or to do something like that. So we take those and we started this engagement to build our trust and work on that level. Can we have community members input so that they guide us to do the work we want that will be important for the community, and they will be able to have feel the ownership. But to have that level of talk to them, we need to build that trust. So the way build the trust, we did like just do it, like be there, and be there. And we had to refine ourselves, like it's all about them, it's all for them. And also I am one of them as well. That's also gave me a lots of pleasure, enthusiasm, excitement, because I am one of them as well. So we did lots of things, the work on trust and partnership. So we did the community events. So it's more of a, we went to different festivals. We took our students. We took our, lots of health promotion materials. But the main thing was to let them know we exist. In the initial days, we had a booth. It's, University of Calgary, the red color one, the orange color one, Department of Family Medicine, YPH, those colorful banners. And only few people were coming to us. And then, most of the people were moving around and looking nice in the corner. In this cultural festival where there is clothes, food tables, what is this? What are this guy doing here? And that was mainly, to make ourselves visible to them. So we started engaging with the ethnic newspapers. We started our promotion through health. And a couple of things we are very proud of we did was youth summer learning sessions. So we call it RISE, Refugee Immigrant Student Empowerment. Within our University of Calgary, a few students and graduate students and academics and staff members, we do this one for the immigrant community youths, high school youths, every summer since 2015. And the idea was, if somebody comes to me as Turin and say, Turin, I think I can help your son. And if I see that he or she is doing it without any string attached, will I not be engaged with that person? So we wanted to follow that model. Also, we developed one community scholar and citizen researcher idea, because there were lots of people in the community who wanted to get involved, but they wanted to get involved in a way that there is some win for them. So, like we did that. We created opportunities for them. And then it's good to say that that worked. That worked in terms of they being our guide, they being our partners, and taking things forward. Without them, I don't think I could have totally come to here. I think the biggest contribution to our research is the community themselves. And then community member mentoring. So community scholar, citizen researcher, they became our sounding board, as well as, they started developing the skills so they can start contributing to the research and win from it as well. So based on those, so this is not a one project based. This is more of a, developing a relationship, capacity building. They develop their own ways of, doing things. And then we go forward with those. So we wanted to do one exercise with the community so that we learn to how to do things together. Because as you already probably identified, I am a newbie here. I don't have huge experience of research of that I can dictate the terms, or I can, make things happen like out of the blue. So we wanted to do something because we wanted the community to understand how to do things in a partnership with the academia. And I also wanted to understand, like, what will it look like to go into a partnership? What will it look like? What will be the commitments? Can I fulfill the commitments? What I need to think about fulfilling those commitments? So we did this research project. We started this research project. I think the research project here is not that important, but the main component is the learning. So we propose that we will be co-identifying the solutions that we can work on, and then through meaningful community engagement. I think this phrase defines what we have done afterwards, and then how we came up with another crossroad where we had to decide with consultation, with guidance with the community, what will be our next step, or how our program of research will unfold more. So again, as I said, we wanted to do community identified priorities. So what we did, we went to the community, we went to the, our homework, and we found out these are the things that are people complain about when they access the primary care. So I will just give 10 seconds. You don't have to bother about looking at in details. So it's more of a, these are lots of issues. That's the point. Then this is the added components of issues. These are the added components of issues. So you see that there is a long list of things that individuals have said that, oh, this didn't work out for me. We took this one, all this information, and then we asked ourselves, was anything new that we didn't know from our previous homeworks? The question was no, nothing was new, because the problem was people have been doing this for the 50, 60, 70 years. They have been using different models. They have been using, different frameworks to categorize them. The social ecological model and other models. So these all things were categorized and explained. And then we thought about, we should be going for solution now. So that defined us, because we started talking about, okay, so to overcome these things, how can we create some action items? So, the macro, what role can state play? What role can institutions play? What role the citizens themselves can play? Because we started talking about, let's hold the spoon and start feeding ourselves. And then if it works, we can start the state, we can start state and we can talk to the institutions, help us to make it sustainable. I will give you one example. The example is language barrier. It's been a huge issue. I think it came up again and again. I didn't see any single paper where this issue came up. I didn't do any single consultation, community consultation, focus group where this thing didn't came up. It came out by default. But when we talked about the solutions, in the macro, meso, and micro way, when we bounced it, and again, this is a hypothetical bouncing, we haven't gone with extreme methodological research way to get up with this example. This is a just lay example. The way I say this one, okay, so our prime minister, he can wake up tomorrow and he can say that, oh, I will provide this billions of dollars to make all the racialized community and immigrants to be English savvy, to go to school and make it happen. That's a possible solution. Feasible or not, that's another question. But that will take 20 years. And there are some linked programs around it. So that will take 20 years, 15 years. And it takes, a state level or the country level initiative, policy making initiative to do that. So in that sense, macro, it's a long-term game. So then we said, okay, let's start that. Can we do something in the mid-level? For example, all the clinics in Canada has a postal code. And using the postal code, using the Statistics Canada data, we can match those, and then we can identify what are the major languages spoken in that postal code. Then if we take that in hand and go and have a conversation with the clinics, hey guys, we know that these are the major languages in your catchment area. Do you have bilinguality in your staff member to deal with these languages? If not, would you work with us to make that happen? That's also attacking the same problem in another angle. So it will take around, I would say, 5-7 years, meso level. And then what about the micro level that I have been preaching so far? So international medical graduates. So this is a terminology that we use for the migrant doctors, those who immigrated from their own country who were doctors there. But in Canada, they are not practicing doctors. They are processing their way through the system. But can we involve them? I can give you an example. Within the Bangladesh community in Calgary, we have around 120, 130 international medical graduates. And then, one day, I think 10 of them are practicing doctors. So we have around 120 people whom we can engage and have a conversation with. If the Bangladesh Association takes a mic and tell to them, hey guys, can we sit down together? Then after that, can we say that, hey, there are 52 weekends in a year. Let's take out 30 of them because, summer weekends, long weekends, and then the remaining 22 weekends, let's take out the Sundays from there. So it's about Saturdays, 22 Saturdays. Can you 100 people distribute yourself and take a time slot within these 22 Saturdays? Then the association can tell to the Bangladeshi community, hey guys, if you need any help from a Bangla speaking doctor to go with you in your consultation, or you want to bounce things with them to understand it better, please look at these time slots and get your appointment in those times so we can have match and we can arrange our this IMGs to go with you and help you with your health and wellness related issues that you have. It can be interpreter, it can be educator, it can be any role. So that's the micro thing that we can do. And if it works, then we can go out to the policies and say that, hey, this works. And this works probably better. The research comes in there to show it works or not. So that's the way we are thinking about, we can play a role and we can think about all the angles and which angle to take. And it put me in a very, again, another juncture, and with our team members or with our guiding angels, where we should be building our home. So we decided, because we already are thinking about roles of citizens, roles of institutions, roles of states. Yes, they are interconnected for sustainability, but initial ideas where we can start it with, where will our research be housed? So, we got more inclined towards this empowerment, grassroots mobilization, and community, because again, from the same philosophy, because I strongly believe if we can start mobilizing the community to hold the spoon and feed themselves, we have more bang for buck. Yes, the other places there will be improvement going on, and we also will be, improving all levels of the ecosystem. So one thing that came up during this period, okay, so if I want to ensure these things to happen, and if we want to help these components that is coming to us, one thing that we can build upon, one choice was community level health and wellness literacy. This is very important to understand because traditional knowledge translation has been done in a one-way thing, a single dimension. We tend to have lack of engagement, co-creation, co-working, and co-owning with the communities, especially the grassroots communities. We normally tend to, check box by engaging with some organizations. So we need to understand our ecosystem and then build upon it. So again, the definition we are anchoring upon is this. Look at the three main points that they have. The ability of the individuals to obtain, interpret, understand, and use. Traditionally, we have been focusing on obtain. We have been creating leaflet, throw out of the window. We have been creating manuscripts, throw it in the LinkedIn. We have been creating, infographics, throw it in the social media. But we seldom have focused on interpret, understand, and utilization component. Health literacy is not only just giving them printed materials or information. We are doing ourselves a disservice by keeping a very narrow focus, narrow interpretation of health literacy. The reason behind this, when you work in the community, there are a group of people who don't know about an issue. For example, we are talking about the vaccine nowadays, right? Vaccine and hesitancy and everything. There are a group of people who don't know. There is another group of people who know, but they don't care. There are another group of people who know, who care, but they don't understand. Another group of people who know, care, understand, but they don't have access. There is another group of people who know, care, understand, can access, but cannot apply. Now, if I take this don't know, don't care, these words, and then does it not reflect with not knowing is about awareness, not caring is about motivation, not understanding is about the exact literacy word, not having access is an access issue, and applying is the social determinants most of the times? And do you think the only those obtaining information, just putting it here, suffices to improve the community level health and wellness literacy? No, it doesn't. And that put us in a crossroad. Where do we want to work? And with consultation with our guiding angels, we want to work on community level health and wellness literacy component. So this is how it happened. We took a right turn on Equitable Access Primary Care Road. Then we took the left turn with the guidance of our our academic community, my mentoring community, by racialized and immigrant population. We took another turn towards the road on community level health and wellness. And the final turn so far we have taken is the health and wellness literacy component. And health and wellness literacy, again, is not about just the information sharing. We're still exploring, we're still understanding, but we're pretty sure with that, it's not just about information sharing. Now, it is what I am now. It is how it is working now. Research, community engagement goes hand in hand. But again, research is not community engagement is not research, but they can both benefit from it. Now, a couple of things. I think this idea came from the things I have used was this integrated knowledge translation. I think most of us, if you are health research related, you will understand that. The community-based participatory action research, most of the people will understand that. But one thing that helped me is the human-centered designed approach. Yes, it's done in the business market, business side. It's done for a small specific project, but the philosophies helped me. The philosophy of reaching out to the mass, the diffusion of innovation, that idea, that helped me. It also helped me the human-centered design, because they say that you should be empathizing with the cause. That probably we did. That's why I had that dreams of working there. We defined, ideated. Now the prototype and the testing part is coming for the, can we develop something for the health and wellness literacy in the community, and will it work? And another component to work is like, is it feasible? Is it viable? Is it desirable? But those components are there. I just wanted to acknowledge like that human-centered design helped me a lot in my building up this discussing with the community. And the guardian angels, they have been shaping up what we do. And our the research is more of a, this is a journey that I have. So that is where I stop. Thank you for listening to this one. I hope you like the journey that I had so far, and then your contribution, support, encouragement for the next steps of community-based health and wellness literacy. This is more important because our premier Jason Kenney, during this COVID outbreak, have made a comment about the northeast of Calgary. I was not surprised about that, but I was surprised about few people's reaction, because for my last few years of working, I knew that the southeast, northeast, the immigrant dense areas or low socioeconomic dense areas, these places are gunpowder ridden places. It just needs a spark. It happened to be COVID. If it was Dovid, Lovid, Sovid, Movid, whatever it is, if there was a spark, we were working for the disaster. And if we don't think about, Canada is good in treatment-based approach. Oh, get diseased, we will cure you. But COVID showed us, oh no, getting disease is not an option. Yes, for those, chronic diseases, you get it slow and easy, but one day will come when we will get overwhelmed. COVID shows that, like, what happens when we get overwhelmed. So our belief, community level health and wellness literacy will definitely help us to fight slow and easy this, uh, overall health and wellness of the racialized immigrant population. And again, this issue, I believe, is everywhere in different levels with our indigenous communities or with our, Caucasian communities. But my focus is racialized indigenous population, because every community have their own, inner sense and inner, that we need to understand that through deep community engagement, work with them to improve this one. Okay, so finally I stop now. Thank you.
Okay, excellent. Thank you for that. That was a pleasure to hear. And I've just noticed that there are a few questions in the chat box. So what I'll do is I'll just read out the question word for word. And then if I have misread the question or misinterpreted it, just let me know. So we have a couple of comments here. This presentation was just brilliant. Big thanks. Excellent presentation. So it seems like a lot of people are on the same page as me that this was really quite valuable. And there were quite a lot of new learnings from this talk. And so the first question I have here is, so I'll just read it out. It seems like you are saying that the traditional population health approach, for example, for obesity, you need to eat less and move more. This is told to the population regardless of the underlying social determinants of health. Clearly, this is not working, and you mentioned going to the community to ask what they want, which I agree. Now to get to the question. What if there are goals in the community that don't fit nicely into what's traditionally referred to as the healthy factor? Do you run with it, try to change it, try to bring awareness? Or would you think the sense of community might overcome that potential negative practice? So perhaps an example would be the ceremonial tobacco for Indigenous populations.
Awesome question, Levi. I think that will be more of a, working within the community to me. For example, I will give an example that we are working a little bit now. So traditionally, the immigrant communities, they don't have, the vaccine problem. Means, they are not anti-vaxxers, but they are having concerns because, due to this era of misinformation and disinformation, everything is being going, weird. So it's more of a working within the communities, getting the people to buy in, and then, help the community to overcome the potential negative effect of the practice. So it's a longer work, but I think the outcome is strong. And we have seen that this type of activities work in the developing world. So if the developing world, where the education level is much more lower and people are more or less conscious, if that works there, it should be working here. So I'm not sure if I answered your question directly, but I will be happy to chat further on this one offline.
Excellent, thank you. There's another question here. Are there any opportunities for youth to increase health literacy in our racialized and immigrant communities?
Oh, definitely. Definitely, there are opportunities for youth. That's the RISE program, like Refugee Immigrant Student Empowerment we developed. That was the idea behind it, creating mini health champions. It's more of a youth being one of the ways of improving health and wellness literacy in the community. Definitely. That still needs exploration, still needs building, but that's definitely, I believe strongly, that that's the way to go as well.
All right, thank
Thank you.
you. There's quite a few questions here, so I'll just keep going through them. Some really great pointed questions. One of them here is the availability of funding or the engagement of the government a barrier to your approach?
So I'm taking So funding definitely, because like what I understood, most of the time the funding comes to a exotic idea, but probably what I'm working is not an exotic idea. So funding pools are smaller for our work, but on the other hand, believe me, we have been blessed by the community contribution, citizen researcher contribution, graduate student contribution, summer student contribution so much, it didn't affect our growth. But on the other hand, now government's engagement, we recently started going to government again. I think I had to learn their language. I am in the process of learning their language. So let's see how it works out. So didn't have a good chat, have a few chat, but probably didn't have that strong partnership type of building up forward, because still our governments, our Canada's overall approach is like, let's treat rather than more prevent.
And we have another one here. What is the potential for the Academy in taking next steps to work with communities in doing CBPAR, so community-based participatory action research?
I think the potential is undoubtedly huge, because we academia, as well as the other component, we need to work with the communities, but the communities also need to understand, like, hey, as an academic, I need to save my job as well, right? So we have different way of doing things, community have different way of doing things, organization have different way of doing things. Having a conversation and having a common goal normally will drive us forward.
Okay, and the questions keep coming in, so I do want to take the time to read them out. This one looks like a two-part question. Thank you for this fantastic presentation. From the public awareness perspective, how would you measure the success of community-based engagement? And can you give an example from your work? And what are meaningful metrics / outcomes for public campaigns, taking social media as an example?
Okay, so I will start answer the first part, and can I come back? I will come back to you with an answer for the second part, because I think OIPH, our team members are capturing the questions. The first part is like, I think the immediate one is like more of the engagement. Like, as I said, I measured our success. The first few community events we were there, everybody was passing in front of our table and nobody was talking to us, trying to avoid talking. The second and third, when we went to the third, a few people started coming up. Hey, what's up? What are you guys doing here? So that I took a measure of improvement of engagement. Then the number of people coming to our event, the number of new people coming to our event, number of community and citizen researchers we have been engaging, number of few people, community citizen researchers published with us, means they did some meaningful contribution with our work. So we went with those easy measuring metrics in this moment. And the second half, I will come back to you, with an answer through email. Our team members are capturing this question. That will be a long answer. That's why I'm just saying that give me this opportunity to come back, please.
Okay, I'll just give it a few more seconds just to see if there are any more questions. There's quite a few comments here. They're all sort of along the same lines of excellent presentation, a lot of new learnings from this talk. Just want to see if anything else has come in. And also just being mindful of the time. We're coming right up to the end.
So there is one question from Sean.
Sure. Yes, I see this. Okay. In your research and collaboration with community partners, what was the impact of institutionalized racism with regards to access to healthcare? In the community, is there an implicit opinion among non-immigrants that immigrants put a strain on our healthcare system?
So, okay, so the immigrants put a strain on our healthcare system. my work is within the racialized community. I didn't work with this issue on the mainstream community. But if there is a perception that immigrants put a strain on our healthcare system, that probably will be a little bit, wrong perception, because we know that health immigrant effect. Immigrants come to this Canada because the way Canada bring people in, uh, it's more of a the way the people bring people in is more of a through point based system. So no, non-healthy, a little bit of needy, and these ones, the immigrants will not be coming in Canada, apart from the refugee and the way we bring refugee in, that's a little quite different method, but that's a very small portion of the people. So I haven't seen that, but people have said that they have felt that institutionalized racism is against them when they try to access to healthcare. So there was issues, ignorance, most probably the racism in form of misinformed stereotyping, covert racism, and implicit bias.
Thank you. Let's see one here. We do have about a couple more minutes, so I'll just wrap this question here. Thanks for the great presentation. Do you think your approach will work for all racialized immigration populations, or would you anticipate changes to the approach for each ethnicity/immigrant population?
Awesome question, Joshua. Awesome question. So we started our test case with one, small, one small, how to call it, one small community. Then we expanded it within the similar community. So straightforward answer to your question, it will not work for all immigrants. We need to tweak things. The overall model will definitely work, hopefully, but we need to tweak things according to the communities we are approaching. Now, here I normally give the example is like when from 10th floor, you look to the immigrants, everybody looks same. But you need to understand the problem. You need to understand the things when you are going to in the ground floor. But the thing is that to come up with a program, you need to go to the 5th floor, because we cannot afford to create a ground floor based programs. So it's more of a if you're on the 10th floor, you do not understand who is who. Ground floor, you understand, oh, this guy is from Bangladeshi background, South Asian background. This one is Arab. This one is East Asian, Chinese. But the program need to go to the 5th floor. The South Asian need to be lumped together because there are similarities, there are dissimilarities, but the program need to understand those subtle differences. So that's the, approach not need to be changed. I would say it tweaked based on the target group we get. And if we can come up with a overall program of community-based health literacy center or hub, that can be handled through that mechanism. Thank you, guys. I think we are in the end of the time, but definitely those who I haven't answered to you, I will reach back to you through YPH will be giving me those questions. And thank you so much for being here. Jessica, thank you.
Excellent. Thank you, everyone, for joining us. Shiba, you had a comment there and a question for the group. So I think if you could just send that comment to the OIPH email, they'll be able to send that email out perhaps for anyone who's interested. So I just wanted to say to everyone, thank you for joining and for your engagement, your fantastic questions. Thank you, Dr. Chowdhury, for your presentation. Everyone, have a great weekend. Bye-bye.
Bye, guys.